Okay, this is Michael from Blue Sky Bio. I'd like to thank everybody who's joining us for tonight's presentation. As usual, if you have questions during the presentation, please enter them into the chat box next to the video screen. And please enter your details into the webinar attendance form so we could send you the CE credits. Tonight's presentation is the third presentation of a webinar series that we're hosting. There's a lot more webinars coming up on the schedule. So please stay informed, stay up to date to see what's going on. We have a lot of great presenters, a lot of great topics. For the first time, we're actually offering some webinar presentations in different languages, in different time zones to accommodate different countries and different language speakers. We've been very busy updating software. A lot of great changes have been happening. We've introduced fully guided keyless system, which is the topic of tonight's presentation. And we have a lot more plans coming up in the short term and long term, so stay up to date and stay informed. Tonight's presentation is going to be given by Dr. ARMEN MIRZAYAN. Amongst many other qualifications, he's the founder of CAD-Ray.com. He's helped and assisted countless number of dentists. He's also one of the co-founders of the Blue Sky Bio Academy, an educator and somebody that definitely plays a valid and active role in influencing modern dentistry. The topic tonight is the importance of the fully guided kit, how it affords you great flexibility and makes your surgical life much easier. ARMEN?
Yep, can you guys hear me okay? Because Michael, your voice definitely, or when you're talking, it definitely cuts out. I want to make sure all the attendees can hear me just fine. Can they type into you and text you and chat with you, let you know if they're hearing me okay?
Yeah, they could type in, I hear you just fine. They could definitely type in and let us know if there are any issues.
All right, so I'll just get straight to it. We'll cut through the formalities because I just put in a crown on an implant, and then after this webinar, I got to present a full arch case to another patient at 5 o'clock here on the West Coast time, so I don't want to waste any time here. Let's get straight to it. What I'm about to show you is a culmination of about 10 years of utter frustration and a lot of trial and error, a lot of money wasted, a lot of I've purchased different kind of kits. I've spent over probably $50,000 on surgical kits that, which most of them are a complete utter waste now, and it's simply from the lack of knowledge and the lack of understanding how things worked. Personally, myself, I started my practice from scratch in the year 2000. And I took a bunch of implant courses and placed quite a few implants my first 4 or 5 years. And then I had a couple of incidents, and luckily I didn't injure anyone, but it just scared me, and I completely pulled away from placing implants, did not feel comfortable, and didn't think it was worth the risk at all to be in that predicament. So I stopped placing them for a few years. And then once cone beam came along, and once I realized that I can place the implant exactly where I've designed it, I completely understood that I could very easily get myself out of trouble before even numbing the patient by referring the appropriate cases that were out of my element or out of my comfort zone. But being able to predict the outcome, I readily say now guided implants are my most predictable procedure that I do in my office right now. I just got kicked in the kidneys with just a simple DO on tooth number 20. It was the hardest thing I did all day today because I hate taking off that ring, and I go to check the contact. It's too weak, and I butcher it, come back and try and add bulk to it. So I want to put this in context that I'm getting to the core of the material here for you in implantology, and really weeding out a lot of important information you need to. But one of the top things you need to consider when you're placing implants and you're working on a patient is surgical access. So what you're seeing here is a full arch edentulous case, and right now I am struggling. This is about 5 years ago. This is the Nobel Active Kit, and I used the Nobel Active Kit to place Biomax implants. Back then, there were no surgical kits for the Biomax, so you kind of have to make shift or do things or try and make things happen with whatever you had. And you can see how right now this patient is sedated with the anesthesiologist. They're intubated through the nose, and I'm struggling big time. And this was very commonplace with the early surgical kits. I knew fully guided surgery, everything designed ahead of time with the aid of cone beam would allow me to place the implants in theory, but a lot of these kits were designed by engineers who had absolutely no concept of what it was like to work in the back of the mouth. That drill I'm trying to use on this patient is longer than any drill or any wider than a patient can open. So we would make some certain accommodations to this, which would be either carving out a slot on the buckle of the surgical stent to gain access from the buckle. We'd make modifications that way. And it led me to search quite a few different systems. I bought a lot. I wasted quite a lot of money. And I remember certain cases that I would punt simply because I could not fit the stent in the patient's mouth. I could not get them to open wide enough. I could not get the drills in their mouths, and I could not gain access to the site. So I came across certain drills that didn't require any handles or any keys. And you can see here, this is a very simple approach where you start with a short drill, and then you go to a subsequent longer drill, and then a longer drill after that. And I'm pretty much doing the osteotomy in the tuberosity here, and it makes access super, super easy. So really want to make sure I convey that point across clearly. Here you see one of the hardest surgeries. We have implantology textbooks that say don't bother with second molar areas because it's hard to place the implant. It's hard to restore it. Where you saw there with the wiggle factor or the handpiece hitting speed bumps was it's trying to penetrate the cortical bone on the edentulous ridge. But now here, I'm actually getting very easy access to the second molar. I never veer off track, and I start with a short drill. Even with a difficult area to reach of the second molar, by starting with a short drill and then going deeper and deeper with a longer burr and perhaps widen the osteotomy as you go deeper, that's when things started to really take off for me during surgery with this kind of approach. So here what you're watching is actually a surgery I'm doing left-handed, and it's not to show off or anything. It's just easier access because I can come across the surgical stent. I'm right-handed. If I came across from the right side, I would bump into the stent with my handpiece. So I just wrap the handpiece around the back of the patient's head, and I just make sure the stent is held down. I have an iSlide in, an Optrogate in. I just had my assistant take a video of this with her iPhone. You can see how easy it is and how we can stay on track with the drills and the stent and the sleeve in the stent, keeping things in line for us, and then placing the implant through the stent as well. Now, what I really want to make sure I'm doing at this point, I'm going to actually stop for a second, and I'm going to ask you, Michael, I need to know how my pace was. Was that too fast, or am I doing well here? Is everybody engaged with this?
Yeah, I think you're perfectly on mark.
All right. So we'll keep going here, and do not hesitate to interrupt me, Michael, if there's anything you want to add to the equation. Now, separate from the access, I would say that's the number one thing we need to take into consideration. The other thing is I want for the listeners to understand is in the past, we used to design the surgery in 3 dimensions to fit and conform to the surgical kit we were using. What I mean by that is we were forced to place the sleeve in the stent so that if we wanted to use a Strawman kit or a different type of kit, there was a specific area where that ring would go, and oftentimes the position of that ring was extremely inconvenient for both the practitioner and the patient. So now it's completely evolved to the point where we design and we custom make a surgical stent to suit the needs of the surgery. So it's a complete revolution, and it opened the floodgates for me. And one of the things we need to take into consideration is not only that access, but where does a sleeve position go, and what kind of carriers can we use? So oftentimes, premolar and forward, you need to be aware of the edentulous area. Sometimes that edentulous area is narrower than the ring and the stent. So oftentimes you need to make modifications to that. You need to trim it away, or cut away some of the acrylic support that's holding the ring in place. And that could have some consequences, like the ring popping out during surgery, or the stent breaking. So anytime you make a modification to the stent, you compromise its strength somehow. And then there are certain areas, like a lateral, where you can only place a pilot drill, and you cannot do anything beyond that. You cannot go with any subsequent drills and widen the osteotomy, because the space is so tight. Okay, and then we have different carriers. We have carriers for some implant companies that have a fixed length, where they can only be set at one point, where you see in the bottom left corner, that's a single carrier. Same with the Nobel line on the right. You have a single length carrier, but for the Astra original line, the OsseoSpeed S in the top left, you had 3 different heights to those carriers, which meant if your sleeve was bumping into an adjacent tooth, or if it was bumping into the gum and the bone, and it would have limited your access to it, all you got to do is raise the ring by 2 millimeters or 4 millimeters, and then use a longer carrier to get it to depth. So you have to be very aware of all the different functionalities of different surgical software out there, and you have to make sure you took all these things into consideration when planning the surgery. So here, for example, you can see how the ring pops out during the placement of the stent. So as we place the stent in that premolar area, as I was drilling, the ring popped out. And if you're not anticipating this, you don't have the throat protected, or it's the first time you're doing this, the ring pops out. I've seen people absolutely lose their minds and freak out when that happens during surgery. It is not a big deal. You'd rather have the ring pop out instead of breaking the stent, and then you slip the ring back in. Sometimes you need to take a burr to that ring to define its borders, or narrow it, refine the borders, I should say, or do some enameloplasty or contouring of the adjacent teeth to get that to fit. Very, very common issue. You need to anticipate that premolar forward. Okay, so what the Blue Sky software did for us when it was first launched, 3 years ago, when it turned into guided surgery, it gave us finally the flexibility to raise the ring position, to narrow it, to widen it, to set it to anywhere we want. Previous to that, the only software I knew of or was familiar with, most of them were pre-programmed for the position of the sleeve to fit a manufacturer's drill set. So you didn't have the opportunity to customize it. I may be mistaken, but I didn't know of any, because I searched high and low, and they're all very well defined. But the onset of the Blue Sky software gave us the opportunity to move this around. I cannot tell you how important of a point that was, because it made some of the most radically difficult surgeries super, super easy. Okay, so here is an example of a case where the osteotomy was performed, but the ring was raised occlusally 2 millimeters. And what you're seeing me do is torque the carrier down with a hand wrench, and when the carrier touches the sleeve, I've gone to depth. But what I had done in the planning step is I knew that ring would bump into the adjacent teeth, and that ring would not fit in approximately between the premolars. I should say the first premolar and the first molar. So I raised the ring, and I raised it by 2 millimeters. So when I did the surgery, I had to use a 2 millimeter longer drill to compensate for that offset. So the ring was offset 2 millimeters to the occlusal. Remember that word offset. It's going to come back, and it's going to be part of every plan that you design from now on. So knowing that I was going to be completely off by 2 millimeters, I knew placing this and going to depth, I would be 2 millimeters too shy of where I wanted. So I just took apart the whole complex. I took apart the carrier. I took off the stent. I reapplied this fixed length carrier, and then torqued the last 2 millimeters of this implant down manually with a hand wrench until I was flush, or just a tiny bit subcrestal. So that's one of the accommodations you'd have to make to gain access to an area that you would not have otherwise with a fixed carrier. So there you see the carrier is flush down to the bone. The implant is down to where it belongs. And here's yet another example of a surgical case. So I'm going to go into it in more detail and kind of put everything in perspective here. Again, I'm trying to place 4 Biomax implants on the upper and 6 Biomax implants on the lower. What you saw there was a tissue punch and actually remove some bone. So I do that first to make sure nothing keeps my stent from seating all the way down. Now I'm positioning a pin to hold my surgical stent in place. Okay. Now you can see how when I start the surgery, it's pretty easy access in the anterior. It's when I go to the posterior, particularly when I have to deal with the angulation of the distal ones, which is oftentimes 35, 40 degrees, 30 degrees, depends on which line you're using. For instance, for the Blue Sky line, you only have angle abutments to 30 degrees, and you better stay within that range because if you had to custom make an abutment to correct that angulation beyond 30 degrees, that's quite costly in lab fees and multiple steps involved. So again, what I'm showcasing here is the shortcoming of other surgical guides that we used. And this is the Nobel Active one. As you can see, it has keys and it has handles and the drills. There are stops you can apply to these, but they're cumbersome and you'll lose them. The patient is intubated. The patient has their throat pack in their mouth, and they're being monitored by an anesthesiologist. So I'm just going away at the surgery. I'm following the plan. No need to emphasize the details here. And there's a Biomax, and I'm using the narrow platform carrier for the Biomax to place this implant completely. And I use finger pressure as far down as I can go before I am blocked out from going any further. Then I'll take the torque wrench out, and I'll make sure that carrier touches the sleeve. So at this point, I've gone to depth. And you can even start paying attention to your indexing. You can see the walls outside of that carrier, and you can guess where your hexes are going to line up for the internal, so you can start using engaging abutments if you wanted to. The one thing you want to refrain from is when you bottom out, you want to make sure that you don't make a complete revolution. Actually, I'll come back to that point in just a second. Let's show you how troublesome this distal tooth was. So this was actually pretty easy relatively easy, but you can see I'm straining myself to retract the lip. I've got the Optrogate to protect the lip, and it's a very, very tough angle to come in from, and that drill is so humongous and long, very, very difficult to manage. But ultimately it worked out. We used different keys and handles, and we placed another Biomax in the back of the mouth. So we'll take off the surgical stent, and we'll clean out the back of her throat, and we'll do the same with the lower arch. And you already saw a preview of this. The anterior too, super easy. As I go further and further back, I worked so hard to get that stent in place. I worked so hard to secure it in place with a anchor pin, and I'm struggling a little bit here on not the most distal implant, but the second most distal implant, just getting the drill out. And you already got a preview of what I showed you of the last implant placement. So it was extremely difficult and very hard to manage, and it was made the surgery a lot more cumbersome than it needed to be. So there's a post-op scan of the case, and here are the Biomax implants. I'm ready to take an impression. I've got the abutments seated with the plastic transfer trays, and one thing people love when they see this case is how you can go ahead and use the surgical stent that you use for surgery to capture your impression of these fixtures. And I'm so OCD, like most of you listening in tonight, that I make sure I anchor it into place with a Duralay or GC pad or anything else so that you can pour this thing up 17 times and not worry about distortion. Okay, so why am I emphasizing this whole purpose of fully guided surgery? And again, I'd like to stop and make sure and see if there's any questions. And I tend to talk very, very fast. I want to make sure, Michael, you're happy with this pace, and see if there are any questions.
Yeah, if anybody has questions, they can enter into the chat box next to the video screen. So far, we're proceeding well.
Okay. Fantastic. So why do I keep emphasizing this whole concept of fully guided? So just to make it clear, fully guided means everything is done through the stent. The initial drill, the subsequent drills, and the implant placement through it. So a lot of surgeons will tell me, hey, Armin, all I need is a pilot stent. I take off the stent, and I can uniformly widen the osteotomy. In my hands, when I do it, after I do a pilot hole, I take off the stent, and with each subsequent drill, I veer off track. And not to be offensive here in any way, but as some of you may know, I run an imaging center here in Los Angeles, a couple of locations, and one in Chicago, where we image other doctors. Actually, most of our purpose is to plan and design cases and teach doctors how to use them. So we see a lot of mishaps. This one is actually, I just took off the internet. If I don't even know who posted this, if you're on here, don't raise your hand so we don't know. But you can clearly see on the picture on the left, the osteotomy was going one way, and the freehand implant placement went a completely different other way. In fact, we have implants in our inventory that are designed to create their own paths and correct any angulation or placement issues from where you started in mid-placement. So we have very aggressive implants that can actually change paths from the osteotomy. And I see this quite a bit. Here's another example. We had a doctor who designed a pilot drill just like this. You can see the implant was well within the bone during the design, but during the placement, the freehand placement, it perforated through the buccal. And there's no reason to be in this predicament. You could have even angled the abutment a little bit to avoid this particular situation. So all of that preview was to bring me to the step where we talk about the new, relatively new, fully guided kit from Blue Sky Bio. And what you're looking at here is a great thought out process of drills that are essentially at the hub the same width, but the lengths of the drills are varied, and so are the diameters. Excuse me. So in this particular case, we have an assortment of drills that can help us start with a very short drill, get a purchase point, and then each subsequent drill can go deeper and wider. So you're no longer confined to going to the absolute width and going down to the depth. Some people are alarmed about that. That's how the Blue Sky Bio direct cut drill works, but many people have reported a lot of success with that, and that's worked out just fine. But this gives you the luxury to deepen the osteotomy and widen it as you go down. Also, more importantly than that, is to know these the measurements of the drills themselves, and then also to appreciate that you have a variable length delivery device or a carrier. So you can, if you have placed an implant and you see that by design your sleeve is bumping into the adjacent teeth, bumping into tissue, bumping into bone, with this case I'm about to show you that we're working on with Corey that we're going to do live for our March course coming up, we had the sleeve of the stent inside the patient's bone within the 5 or 6 millimeters. So even with that massive offset of 4 millimeters, we're still within bone. So we needed some bone reduction guides, and I'll take you through that in just a second. But you have this variability of just doing simple math and saying, hey, I want to place a 10 millimeter implant, but the way it's supposed to go, I'm let's say 2 millimeters too deep with my ring. So I raise the ring by 2 millimeters and use a 2 millimeter longer drill, and use the carrier and set it to a 2 millimeter higher dimension so I can compensate for that. Yes, I know there is a difference between the 10, the 11 and a half, and the 13. We'll talk about that in just a bit, but it's a conceptual thing I want you to get. So if you don't have this, you can go ahead and take a screenshot, or this is readily available everywhere. You can see the exact dimensions of the guide tube, the position, and the offset, where the height is, the height of the tube, where the offset is. And to keep it simple, if you're going to use the 8mm drill, your offset's at 8, so you raise it by 2 millimeters, then you have to compensate for that by using the 10mm drill. Very, very simple concept once you get exactly what you're doing. And what I wanted to show you now is to transition to this big case. And Michael, please let me know if everything's visible here.
Yep.
What I want to draw your attention to is this particular case is posted for you to watch as we're going through the whole process. So once you're on the Blue Sky Bio Academy, you can go to the discussion forum. And in the discussion forum, this case, let's wait for it to load. We have the guided surgery button here. Excuse me. And at the very top of this guided surgery is this big case that we're talking about now. So every step of the process is documented for you. We have a clinical picture. I'm hoping you guys can see this. The patient has already lost the central incisor on the right, and most of these teeth are predominantly involved. You can download the CBT file. I'll show it to you. You can see the amount of bone loss around this bridge. This bridge is actually not mobile at all, but I'll show you in just a second exactly how much bone loss there is around it. So you can download the whole case. You can download the BSB file and design along, and this is what I want to get to. You can see in this patient's smile that he has a gummy smile. He shows a lot of teeth. So whatever we do, we want to make sure our junction for the prosthetics and the implants are as far away from this lip line as possible, or we are doomed. We're going to fail before we get started. So we want to bury those implants. We want to remove some bone. We do not want the prosthetic component showing it all. So you can download the different STLs. We've scanned it with stone models, and the stage we're at is right here, where we have the case set up in the BSB software. So I'm going to go ahead and go to the, make sure everything's crunched up here. Let's go to the implant list, and I'm just going to undo the buttons here. And let's go to the very last implant. And if you're new to the software, again, you may be overwhelmed. I'll try and go at a nice pace here. But here's the upper left implants. And nope, that's not it, actually. This one is. So whichever one is highlighted in pink in this, I hate using the mouse pad. So here you can see that it's in purple. This is the implant we're looking at. And what I want to show you is, let's blow this up and see exactly where this implant can go. As I'm spinning the bone around the implant, certain areas it certainly looks like I have plenty of room. But from this position here, you can see how much bone loss there is around this premolar. You can see the purulence, or the granulation tissue, so the premolar that's perforated through the sinus. So that bridge absolutely needs to come out. You can see the, actually there might be some internal resorption within this root. So there's a lot going on, and what's keeping that whole bridge in place is that posterior molar. So you can see how closely I'm threading the needle with the sinus and where I want this, and doing this guided is exactly what's going to help me get into the right position. Okay, so let's go to the next tooth here, the one that's going to go in the lateral as well, and you can see how I can go well beyond the apex of the root tip for this tooth, and we have plenty of bone to engage. So it's just phenomenal to be able to see all this before you even touch the patient and comfortably do the surgery. Let's go to the other one. Same thing on the lateral. We have plenty of bone. We can spin the bone around the implant and see that we've got plenty of room. In fact, these are 4-3 implants that we're going to place in the central areas. And generally, you don't have that much space, that much bone in the anterior to place a 4-3. You usually have to go with a 3-5. Same thing with this back one. When you look at this view, you're like, oh, that's plenty of bone to work with. but it's angled, and you're encroaching the sinus, the floor of the sinus, quite a bit with this implant. And that one is an 11.5 millimeter implant. So a broad overview of this, and let's move on to this image here. And again, with the track pad here, it's very difficult to see, but you can see from this view here how well the implants are positioned. And from the occlusal view, and make this a little bit smaller so you can see, oh, let's undo that because I haven't locked it in. You can see from this view how important it is to see the path of draw of the different implants. They're all coming through the linguals of these. I'll adjust that this back one later to have it draw more with the ridge. But one of the biggest sins in doing this big hybrid cases is to place the implant too facial or too buccal and have it be visible during the prosthetic portion of the case, and the patient's super unhappy, and so are you. And the lab costs skyrocket to correct that angulation. You always want to finish your path of draw to the palatal of all these teeth, or at least occlusal groove and palatally. You've seen many cases of these hybrids where the screws are actually 15 millimeters up the palate to place the prosthesis. Whatever you do not want your line of draw to finish facial to your desired restoration. Now, what's awesome about this is we have the teeth in space. We know exactly where the implants belong. The front too, we had quite a bit of leeway. The back too, we don't have much room for error in terms of where it goes. And what we're going to do is we're going to sequentially make multiple stents. So again, a year and a half ago, stents were so expensive, and the design process was so cumbersome and long. It can be for these big cases still. But instead of making a single stent here, we're going to segment this and do it in sections. What I mean by that is I'm going to have one stent made where I section that bridge, but I keep that back molar as a rest for my surgical stent. And then I selectively remove some teeth. And after I selectively remove and extract some teeth, I place 2 implants. And then once those are placed, I'll use another stent after I remove the remaining teeth to place the next 2. So what we have here is a video that Corey was cursing me for today. Let's turn up his the volume. Let's make sure you can hear him. I don't think he does curse at me live here. Let's find out. Oh. Michael, let me know if this doesn't come through.
I just want you to know I totally hate you for sucking me into this case. I burned like 8 hours trying to figure out a way to do it. So let me show you what I've come up with. I did my own bone segmentation of the maxilla and everything. I've got a good segmentation. And then I also went back and I merged in the tooth model and then combined that with the segmented jaw so that you have accurate teeth rather than distorted ones on this maxilla. So from there, I got to looking, and I know you wanted to do it tooth supported if possible. And this was going to be a very difficult case to do, the full bone reduction guide and everything. So I'll show you what I've got here. Let's see if I turn this one on. I went back and I virtually extracted all but the canines and that molar, which puts that stuff there. And then I went back and I made a guide. I made bone reduction guides. So what will happen is you'll extract all of those teeth. You'll pop this guide on, supported by the canines and that molar. And then you're going to come in and you're going to do bone reduction, but you're only going to do it in these specific areas because the goal is you're just trying to get enough cleared out that you can put on the secondary guide and be able to fully guide the implant and still keep it all hard tissue supported. So you'll do that. This will have to be done with a high speed because you're going to be reducing some into the bone and then some into these teeth, but there are still enough of those teeth there to support it. So you'll do all that, and then finally you'll stick on this guide, which looks like hell right now, but we'll clean that up after it's been printed and shape it so that it's a little more nice. And this is the guide that you'll use to fully guide the implants in. So the implants will get fully guided into place, and then you can remove all of the guides. And I think your best bet for reduction is just to then break out your high-speed handpiece and just connect the dots. You'll chop off this area, You'll smooth and taper this little area of bone in. You'll extract this tooth, chop here, and basically you're just going to profile around those implants with the profiler kit. And that should have everything. And then I've still got to figure out the prosthesis, a good and accurate way to index that. But I'll get that done. So take a.
So what you just saw, what he was just saying at the tail end, we're also trying to get it so that we can take these implants that are in the model. We're going to virtually seat them, or we're going to go to the software where it lets you seat the and create the analog holes, but we're not going to have a model printed and seat analogs in them. What we're doing is we're digitally placing the implants in the model, and we're going to transfer that to the lab and have the lab fabricate a prosthesis digitally on that. And what's great is the lab has already the bite, the opposing, the vertical dimension of the teeth, because that's already been digitized from a cone beam scan of the upper and the stone model. So they'll be able to plot the teeth, and Corey's working on that himself to get the restoration design and just send it off to the lab, so the prosthetics are pre-made. I can't get access to my threshold for the CT on this screen to show you how the CT and the this model mesh together and how well they're adapted. It's a very important step of the process as well to make sure it's stitched properly. Actually, let's go here and take a look. Let's give it a hint. So really, really critical for our accuracy is this step right here. We have two digital files, and we've fused them together. One was the digital stone file, a cone beam scan of the stone model of the patient. And you can see here the back bridge with the PFM has a lot of scatter, and our orange line doesn't circumscribe it as well, but the front 6 teeth are very nicely circumscribed. So let's see if we can enlarge that and kind of panel through this. And it's really important to make sure that these are as closely adapted to each other as possible. If there's any gaps between them and you don't see a great adaptation, your surgery may be off from this. So I can't play with a threshold because my screen's too small to accommodate the software, but you can see how much control you have of the situation. And my experience level, even though I've done plenty of implants, is I do not ever want to touch a patient without having it pre-planned and having the stents and the fully guided kit give me the exact precision that I need. And if you've ever done any of these cases, you know very well that at the tail end after the surgery, sometimes the conversion of the prosthesis takes longer than the surgery itself, because you got to convert that temporary partial to draw and do a pickup impression. That you may even have to have a lab tech in the office to do this. But all this will be prepared ahead of time so that right after the extraction and the implant placements, probably the only thing that will trip me up is to know exactly how much bone to reduce to deliver the appliance. Now, if you're super in control and you're super in touch with exactly what's going on, and you can start moving to engaging abutments. You can start perfectly lining up the abutments, even with the angular ones, to draw with either with your MUAs, your multi-unit abutments, or with your prosthetic level ones. So everything's pre-made ahead of time. And once you deliver the implants, everything's delivered at the same time, and you no longer have to worry about the right vertical dimension or the right bite or if it's seated all the way, because all that is done digitally ahead of time, and you keep track of that. So it's pretty incredible to have that much control over the whole situation. That's exactly what this surgical kit will afford us. And this was an extreme example. I thought it was a great example to show you how all the pieces will come together. I have difficult implants to place in the back of the mouth that's angled. So I'll start with the short drill and go deeper and wider and go to the 4-3. You also should know that after the 4-3, if you wanted to place a 5-0, there is no drill for that. You have to finish that freehand. You already know my thoughts on freehand, so I'm perfectly comfortable doing 4-3s here and having them angled at the distal and attaching the appliance to it. So that pretty much is the formal thing that I planned for you guys with the topics for today. And I want to make sure I take the time to stop and give you guys a few minutes to ask any questions. Michael, is there anything you want to add to this?
No, let's get started with some questions that came in.
Okay.
One question that came in is if the Versa burr can be used for guided placement.
Yes, once you figure out how everything works, I mean, literally all you have to do is take a digital caliper and measure your Versa drill's diameter, or even smarter than that is look up their manual and read what their diameter is. And then all you need to do is create a stent with a hole in it that can accommodate that drill and the ring. And Blue Sky Bio's got all of that on their website. You can find the exact ring, which will have an inner diameter that'll hit that'll match the Versa burr, and you can have an outer diameter. And once you have those dimensions, you can easily design the case to accommodate the Versa drills, if you wanted to, or just run your other drills in reverse, and it accomplishes the same thing.
Okay. What's your recommended drilling protocol using the fully guided surgical kit? There are different widths and different lengths, and I know that some doctors are using it in different sequences. What do you recommend?
Yes. The argument has always been if you go to the final width right away and you just go deeper and deeper, you may have a zone of necrosis around the outer boundary. The folks at Blue Sky, Dr. Sheldon Lerner, have provided plenty of literature that says to the contrary, as long as you're using copious amounts of water to irrigate the area. I would readily admit for at least 5-6 years, that's been my approach, kind of like the one cut drill or the direct cut drill where you just go to the final width and you just keep going deeper and deeper. And I've had no issues. But since we now have the luxury of having both control over where we start and where we end in terms of depth and width, I would recommend we actually do everything we can with any other combination of drills, and then the final drill would widen the osteotomy and take me to depth. So I hope that was pretty clear. Since we have all these drills, since we're already have all the components, just start with a narrow one and a short one, and then work your way up and just make your final drill be the one that goes to the final width. And that width usually is about 0.3, 0.4 narrower in diameter than the implant you're going to place. Ideally in the maxilla with a soft bone, I'd prefer to have the diameter of the osteotomy good 0.5, 0.6 narrower than in the lower jaw. I like it to be about 0.3, 0.4. And I'll readily admit, having done this many, many times, I cannot tell what kind of bone I'm drilling into because the adaptation of the ring to these drills is actually much tighter than the finger pressure as tactile sensation you get from drilling into the bone. So I can never tell if I'm drilling into soft bone or a hard bone. You just know from your basic biology where that kind of bone is.
What are some points that somebody who's getting started with a fully guided kit for the first time should be careful about, or pitfalls they should avoid, or extra tips they should be careful about?
There are quite a few. So I've kind of battled this in terms of telling people, oh, all you need is a cone beam or a cone beam image and do it fully guided. I want to make it clear that with fully guided, the opportunity you're given is a few things. One is you can get out of trouble before you even get into trouble by properly designing it and seeing the bone, seeing the limitations of the case. I can't tell you how valuable it is to punt the cases that can make your life absolutely miserable. I still refer a good third of my cases. So that's number one. Number two, all this stuff, all this technology, all it does is give you the opportunity to place the implant as close to where you've designed it as possible. Many, many things can still go wrong in that whole process. You could absolutely design something wrong. If you notice, I emphasize at the very end how our scans, our digital scan of the jaw and the digital scan of the stone model had to had to fit each other perfectly. Well, if you didn't do that part correctly and you didn't stitch them together and they were off by just a fraction of a degree or a millimeter, you know, in really tight spaces, it can get you in a lot of trouble. So that's the prelude to what I'm going to say. The next thing I'm going to say is the cool thing about guided implantology is, and I do get into trouble for saying this quite a bit, it eliminates probably about 60 to 70% of a core curriculum on implantology. It does not replace it, but it eliminates a lot, because a vast majority of the time is spent trying to figure out what to avoid, where the critical anatomy is, where that distal root tip tips to the distal for a canine, where that concavity is. There's nothing you can do with palpating and sounding bone to find that lingual concavity. And you perf that, you're probably never going to place an implant again. It's going to scare the living heck out of you. So I'm of this found belief that you should not drill into a human skull unless you know exactly where you're headed, and the guides and things will get you there. So I think a very good approach for somebody who's never ever placed it is, I would say, not to toot our own horn, but I would say start with one of our Blue Sky Academy courses, because what we give you is the overall picture of where you're headed, where dentistry is now, where everybody else will be in 5 years, 10 years from now. If you start the journey fully guided, you leapfrog probably over 20, 30,000 clinicians who simply don't have the advantage you do, which is having a GPS guided approach to placing implants. So I'm very confident if you follow the steps and do it right, you can place it exactly where any specialist can place it. It's just, how do you manage the tissue and the bone around it? So your education's never done. Take as many courses as possible. You've got courses offered by multiple different entities, free ones, online ones, dental institution ones, implant company ones. You can never learn enough about implantology, but I think it's kind of good to step back and get an overall picture. And I guarantee you, and you may have witnessed this, I've converted many people to doing things guided, including Corey. That's exactly how we met, it because I hassled him so much about placing implants freehand, and now he won't touch another human being without using a guide and have the cone beam direct the path of it. So if you get that overall picture of where you're headed and how you can get into this, what's really awesome for you is your startup costs are extremely minimal. So you can get into placing implants fully guided and do them at a profit margin from the get-go with everything that's been developed by Blue Sky Bio. Whereas when I started almost 20 years ago, I spent $50,000, $60,000 on courses and implants and things, and I was still gun shy about placing them. And it took probably 2-3 years to recoup the amount of money I invested into starting to place them. Once you get the hang of this, once you understand how everything works, people learn at different paces and degrees. Some people jump right in, take a beating, and shorten that learning curve. Other people, obsessively review, analyze, cross their T's and dot their I's before they start doing it. A couple of things I would add to that is, no question, placing implants, it's going to be a huge part of your practice and the growth of your practice. The more you place, the more comfortable you are, the easier it is for you to present cases. In the last 7 days, I've presented 3 full arch cases where they're going to have extractions, they're going to have implants placed, and a prosthesis delivered. And there's no way you can do that without having the confidence of knowing what the end result's going to be, how things are going to work out, and just being able to present it to your patients with them acknowledging that you're the authority on this and you understand it, and you're going to do it the proper way. And about the best thing I do for case acceptance is to make sure I show them what a stent is. I show them how to what fully guided means and how the implant's going to go where I've designed it, and that I will not risk doing any harm to them by doing it freehand, because when they leave my office, I don't want them searching for a cheaper solution. I want them to come up with a solution that helps them pay for this stuff over a period of time, as opposed to trying to find a cheaper solution from somebody down the street.
We just had a comment that came in. Quote, I have the keyless kit and love it. I would recommend it to anyone. It saves so much time.
Absolutely, no question. Huge, huge accomplishment from Blue Sky, and I believe you guys have said it's the most expensive thing you've done is to develop this kit, and it's simply because we harassed you for so long, right?
Yeah, I think so. Another question that came in: why does the first drill have cutting sides on the upper part of the drill? Will that not cut the plastic of the keyless guide?
A great question. So, any one of these drills, I'm of the opinion, can actually shave some of that acrylic and drive it down to the osteotomy. So, well, actually, Blue Sky Bio themselves say that you can use no ring and just go straight drill and contact with the acrylic. My personal preference is to have a metal ring in the sleeve so that you don't shave any of the acrylic and drive it into the osteotomy.
Yes,
You
we
will
recommend
come
using a
across.
metal sleeve as well.
You do? Okay. Yeah,
Yeah.
last time, Dr. Sheldon, you guys didn't think it was, that I would imagine from a manufacturer, you absolutely want to put that disclaimer in. But you will come, I will readily admit, you will come across clinical situations where it's just impossible. And generally, the rule is when you most need fully guided kits and systems is usually the areas you can't use them, especially like on a lower incisor. You can see how on a lower incisor implant, virtually there's no fully guided solution from any manufacturer because that space, that edentulous space, is narrower than the ring or the drill. So some people take that risk and make sure it's nicely lubricated so that no shavings from the acrylic come off with these drills.
Okay, just to respond to a couple of questions that came in, the software could be used to treatment plan any size implant, and it could be used to fabricate a surgical guide for any guided surgical kit from any implant system. And we carry a very large variety of different metal cylinders to accommodate different guided surgical kits. But of course, we definitely do recommend checking out the new fully guided kit from Blue Sky Bio and all the advantages that come along with it. Another comment is that the Blue Sky Bio Academy Facebook group is a fantastic resource of clinicians that are very generous with their time, giving a lot of comments and feedback, providing a lot of educational material. And of course, the Blue Sky Bio Academy website is a fantastic learning tool and resource as well. So definitely recommend checking out the Facebook group and checking out the Blue Sky Bio Academy website as well.
This is to answer the first comment you made. So basically, we have a cheat sheet that Joe posted of every guided kit out there. I would avoid most, if not all of them, unless you already purchased them. So, for instance, you want to use the Straumann kit. This will tell you exactly what the settings are to be able to use their kit to parlay with what Michael was saying. So you have that available to you. And yes, the Facebook group is pretty active. But on the website itself, you have a ton of tutorials. You can start on reviewing some of the stuff I brought up today. We have, anytime something new comes out, we post it here. There are practice cases. There's the orthodontic stuff that Baron's going to come out with very, very soon. And the Blue Sky Bio software is coming out with. And yeah, it's an ongoing process, and an absolute shameless plug. Our courses, we highly recommend you take as many courses as possible, absolutely. And we have quite a few that we do here in Los Angeles, and we have a traveling course as well. Our next course is coming up in 2 weeks. It's a big arch case, and actually the prices went up. Actually, the prices will go up tomorrow. So if you want to come out to Los Angeles and watch that case done live at my office, get in before this price goes up tonight to $2,000. It's in downtown Los Angeles. So we'd love to host you. Other than that, I think I've covered everything I wanted to. Michael, unless you have other things for me to address?
Yes. Question came in if you could discuss the importance or the relevance of the drill flattening the bone around the area of the osteotomy.
not flattening, but heating the bone. The thought is that if you're at the full width as you're drilling and going deeper and deeper, and you're not cooling the area enough, the speed of the burr can heat up the bone, and it doesn't take much to necrose the bone in terms of heat. Like I said, plenty of arguments or research that contradict that, as long as you have copious amounts of saline that keep the bone from heating.
Okay. So I think that pretty much wraps up the presentation. I know you're tight on time and going off to treat some more patients. Just a couple of comments, technical issues from the beginning that I mentioned. Everybody should make sure to complete the webinar attendance form. The link is in the chat conversation next to the video screen, so we can send you the CE credits. We have a lot of other presentations scheduled over the upcoming months, so definitely recommend checking out the upcoming webinars and take advantage of those. There are a lot of updates coming through in the software over the next couple of months as well, so we definitely recommend staying up to date. There's the Facebook group, there's the Academy website, of course there are the live courses, a lot of resources to take advantage of, and of course with any questions you can also contact Blue Sky Bio. You can email us at plan@blueskybio.com or call us and we could provide support as well. So Armen, I'd like to thank you very much for taking the time, providing another fantastic educational experience.
Cool. Happy to do it.
Thank you to the entire Academy team for everything that you guys are providing and all the assistance you're providing. And I'd like to thank everybody who's attended the presentation, and we hope to see you again soon at a future presentation.
Thank you.
Thank you. Take care.